Slalian. I'm the new Chief of Research with the Department of Aging. I've had the pleasure to meet some of you already. Look forward to meeting the rest of the partnership group today. I'll be providing some background about myself here in about 5 minutes or so, and we'll be available to answer any questions you may have. So we'll get to know each other better during this time. And today's a really important day for the Department of Aging. We of course have a research partnership meeting today, but it's also Master Plan for Aging Day, or MPA Day. A lot of folks are coming directly to this research partnership meeting from the MPA kickoff meeting. It's a day for us to look back on the successes over the last 2 years, and also look forward to exciting opportunities and important work ahead of us. And I'm extremely excited to collaborate with this partnership group and using today as kind of a foundational meeting, which will set us up for success going forward. So to begin our meeting, I'd like to hand it off to the Department of Aging's Director, Susan Damaros, for opening comments. And Susan, can I hand it over to you, please?
Us and welcome. I just can't, I was looking at that first and welcome to all of you. It's great to be here this morning. I look at that opening slide that says January 20th, 2023. And if you look back to January 20th, 2022, this committee did not exist. Sarah Steenhausen had been on board for 2 whole days. And Ross was busily working in his former role and didn't know about us, and we didn't know about him. And my gosh, how far we've come. So I just want to thank all of you. This is perhaps one of the committees that is most ambitious and holds a sense of urgency that I sure do appreciate. And I think we're resourced now in a way to support that. So I just, want to encourage you to just full steam ahead. If you were on the webinar just a few minutes ago, we're really trying to focus our work. If you, think of a reverse funnel, and the beginning was very broad. And as we narrow over the 10-year roadmap, blueprint for our state, to really get down to with much more precision over the ensuing years. And you're key to that, with the key outcomes to really help us focus and hone in our work on true system change. And this partnership is key to that. So I just want to welcome you all. Thank you for your time. Your time is so valuable, and we really appreciate your expertise, your knowledge, your suggestions, your creativity and innovation. Thanks for being here today, and I look forward to listening and learning from all of you. Back to you, Ross. So glad you're here.
Thank you, Susan. And I'm going to hand it off to Elizabeth Stephenson, who's going to also provide some opening comments. Thank you, Elizabeth.
Great. Thanks, Ross. Thanks, Susan. Fantastic to be with you all here today. And good morning. For those of you who don't know me, my name is Elizabeth Stephenson, and I am the Acting Deputy Director at the Insights Lab over at the Center for Data Insights and Innovation. And it's really really great to be back here with this group, to stay connected to and aware of our respective efforts, and to really be mindfully keeping the door open to collaborations. I know in past meetings, we've been pleased to share about some of the data products in development at CDII, including the All Hazards Dashboard and the Equity Dashboard. And these products, as well as some other data-centric efforts that are just getting started now, are all leveraging an internal data system we're building called the Agency Data Hub. And we are so excited about the potential for the Data Hub to support data sharing efforts and hopefully resolve some of the known pain points around data sharing. So a little later in this meeting, our Chief of Data and Engineering, Simi Kichalot, will be sharing an introduction to this data system. So thank you so much, Ross, and thank you all for your partnership.
Thanks, Elizabeth. So next, I'm going to hand it over to Sarah Steenhausen, who's the Deputy Director over Policy, Research, and Equity with the Department of Aging, to provide updates. So Sarah, I'm going to hand it over to you. Thank you.
Great. Thank you so much, Ross. It's always wonderful to see you all here. I just want to say this committee continues to be the most engaged, active, and productive. It's incredible the work that you all are doing. And I'm so excited to have Ross in his role as our Chief of Research. He has jumped in. He's been here for just 7 weeks, and he has just really done an incredible job of working with all of you and advancing this work. But I also want to thank Terry Shaw, who continues to be really critical to all of this. And we really, really would not be here if it weren't for her support and work on these issues these past few years, actually the past 3 years before the MPA was even developed. And Terry's really done an incredible job of working closely with Ross to onboard him. And so Ross's success is due to a lot of the support he's getting, and we look forward to continuing this work together in the years ahead, I should say. So what I want to do right now is just give a few updates, state level updates. If we can move to the next slide. So for those of you who were not able to participate earlier on our launch of the new initiatives for the 23-24 Master Plan for Aging, we're really proud that this morning we did launch both our 23-24 initiatives as well as the annual report reflecting on the work of the past year of MPA implementation. We can put up in the up in the chat, a link to the new initiatives and the annual report so you can look through it. But what I really want to call out is that all of you in your work over the past year, as well as in your work in presenting to the day of action, the priorities of this committee, that work is so critical in informing the next iteration of the master plan. So we really developed the initiatives based on the input we received from stakeholders over the past few years. And we hope that you can see your work reflected in that. But I also want to note that it's, the plan is a really important blueprint for our work moving forward, but by no means should we limit our work to everything we see in the plan. I think it's a guide, and we want to continue to iterate and update the work together. So look forward to your feedback and to your continued engagement in it. I also want to note that for the first time, we have now a Master Plan for Aging implementation tracker. We would not have been able to develop this were it not for the support of West Health and particularly Zia Aga. I remember it was last summer. Amanda has been working really hard on trying to launch something like this. So instead of one report that has a point in time reflection on where we are with each of the initiatives, we now have a tracker that enables us to get more regular updates on each of the initiatives and where they are in the process. And it enables our state partners to populate the initiatives with the work that they're doing, as opposed to just releasing one report at the end of the year. We called Zia last summer because we were having some challenges on developing this, and Zia and his team at West Health were just incredible partners, put a ton of time and resources into it. And I'm really excited for you all to be able to kind of look through, peruse, and explore how we've developed the tracker. And of course, that along with the data dashboard for aging, which is such a key part of this committee's work, we will continue to iterate and update as we move forward. So thank you again to Zia and to Amanda for leading in that work. Next slide, please. So this is just a little bit of a focus on the implementation tracker and how you can access information in there and filter by different goal areas and strategies. And so Jackie, thank you for putting a link up to it. You can explore that and peruse it at your leisure, but really are excited to have that in place. Next slide, please. So what you'll see in the new initiatives, we have 95 new initiatives that again were the reflection of the work over the past few years and what we have heard from our stakeholders. Some of these initiatives are taking forward some of the 21-22 initiatives that we've updated. Some of them are new initiatives that came from feedback we got. So you'll see that we've kept all of the same 5 bold goals and strategies, but you'll see new initiatives reflected throughout all of it. So it really is, I think, a good pathway forward for us in the next 2 years. And of course, at the end of 2024, we will have the same effort where we will turn to all of you and ask for your input as we launch the 25-26 initiative. So looking forward to working on all of these components with all of you together. Next slide, please. What I wanted to do now, and then I'll turn it back over to Ross, is just highlight a few of the initiatives that we are launching at the Division of Policy, Research, and Equity. We don't have a lot of time to talk about all of these individual initiatives, but our partners have been so key into helping us advance it. But really excited that we're launching a few key initiatives, two of which are from grants that we got from the Federal Administration on Community Living, focusing on developing a dementia-capable no wrong door system, and establishing a no wrong door state leadership council. So that's work that's currently underway. This afternoon, we are presenting with the Department of Healthcare Services on the HCBS gap analysis effort. This is a really key effort for the Master Plan for Aging, and I think will intersect with the work of this committee. Essentially, what we're doing is we're trying to track where services are currently available, where they're not, and looking holistically across the state, across both Medi-Cal and non-Medi-Cal home and community-based services, to give us a good picture of where we need infrastructure developed. And then from that, the plan is to develop a multi-year roadmap to build out our statewide home and community-based services infrastructure. So if you're interested in attending, that meeting is today from 1 to 3. DHCS's gap analysis is separate from ours, but it's we're working on it in partnership and in communication with them. So that will be important as well. We're also launching our workforce initiative called Cal Grows. I don't know if Heather Young is on yet, but she's been providing a lot of technical assistance on that as well, which is CDA's Direct Care Workforce Initiative that really is, I think, going to have some very promising innovations across the state that we will learn from. And then I don't think I have time to walk through all of these, but we're doing a lot of different initiatives that are in the planning phases. We're working across departments to develop a state level community of practice across aging and disability so that we can better align services as people age with disabilities across developmental disabilities and physical disabilities as well. We're launching the Healthier at Home project, which is going to be releasing an RFA later this year. Amanda has spoken about our age and disability planning grants that we are about to launch an RFA with under Jackie Tompkins' leadership. Jackie is on the webinar today, and she is our new senior strategist for the Master Plan for Aging and has just done an incredible job leading that effort. We're also really trying to build out our no wrong door system through the development of a consumer contact center, consumer-facing web portal, so people can get all the access to the information they need in one place, no matter where they are in the state, as well as our customer resource management program, the CHARM system, that will be the back end of that system. So these are works in progress. We have not launched them. We have a lot of work to do, but it's kind of something that we see as part of this larger 10-year effort as part of the Master Plan for Aging. And finally, in concept development, and I know we'll be talking about some of this today, I'm really excited about the work that this committee has done on particularly David Lindeman and Marcy Adelman in advancing this concept of an LGBTQ statewide study of the needs of older adults who are LGBTQ. Ross has been working with some of you on thinking through what we might do to establish a research consortium. We are also going to be doing a lot of work to address LTSS financing and affordability, and establishing an Institute of Learning and Innovation as a way to have standardized training and technical assistance for all of our network leaders, volunteers, and staff that work on these programs. So that was a lot of information in a few minutes, but I just wanted to give you a little bit of a flavor of some of the work that we're doing in our division. And I know that some of this work will be brought to you and you will be helping lead as well. So with that, I want to turn it back over to Ross.
Thank you, Sarah. So the next agenda item, we could go to the next slide, please, is what I'm going to walk everyone through. Is where I'm looking forward to how we can leverage research and data development to support the Master Plan for Aging efforts. I'd like to share my vision with you all for the type of team I like to build out to support these efforts. And I want to keep this meeting more of like informal conversation. So there's going to be time at the end of each agenda item to ask for questions. But please feel free just to hop in with questions or raise your hand. If you want to use a chat feature, that's fine as well. So I thought I would start off with some background about myself at a high level. My academic background is mostly in economics. I'm a proud first generation college graduate. As I was completing my undergraduate work and kind of thinking about what my long-term career goals are, I found a need to have a career that's centered around, giving back and helping underserved communities in some way. I think a lot of that comes from my family and my family's history. Both of my parents were born and raised in Fiji, and they come from humble beginnings. And as I've gotten older, and I felt and continue to feel this fortunate, lucky to have the opportunities that I've received. My parents, my aunts and uncles, other my family members haven't received these opportunities, and that's been significant in kind of shaping my outlook and some of my passions. So the concept of equity, that's very important to me. I was eager to join the Department of Aging and support the Master Plan for Aging because equity is a central component to everything within the MPA. And research centered around equity and trying to find solutions and tracking progress of strategies aimed at these equitable outcomes is something that I feel is important and something that I'm passionate about, and which is why I think this position and working with you all is going to be a really great fit for me and something that I'm looking forward to. So I've only been in this position for about 7 weeks. And before joining CDA, I was the Healthcare Workforce Development Research and Evaluation Chief with the Department of Healthcare Access and Information, or HCI, for about 6 years. I led a team of researchers there, and our work primarily focused on health equity issues with the lens on the health workforce. I really enjoyed my time there and had the opportunity to build a really good team. We use data to identify underserved communities in regard to the health workforce. So areas that lack primary care services or behavioral health services. We conducted research to try to understand some of the key drivers that led to this underserved status. The team at HCI does awesome work around administering many different health workforce grant programs that support these underserved communities. So these grants provide incentives for health practitioners to practice in these underserved communities. And my team helped with program evaluation efforts and collecting program data to better understand if programs are meeting these intended goals. I'm also helped stand up the Health Workforce Research Data Center, which serves as a central repository of health workforce data. So work directly with several state departments and other organizations to develop data sharing agreements and build out a database of high quality workforce data to better understand supply and demand issues around our educational capacity to produce an adequate health workforce. Before joining HCI, I was a team member for the two big pension systems in California, CalSTRS and CalPERS. So with CalSTRS, that was my first job with the state, and worked in the benefits area. And that was a great first job, trying to help our public K through 12 public teachers enjoy a decent retirement that they deserve. At CalPERS, I worked on pension research activities. An example of a project I led there was understanding how our pension payments impact the state economy. So I think my background, especially my time at HCI, has a lot of parallels of the work that I'll be conducting here at CDA. Team building being one big aspect, also collaboration. I've been really impressed with the partners and stakeholders that we have the opportunity to collaborate with. You all, I think the passion and energy is contagious. You all really care about this work. There's a lot of innovative thinking about solutions. And I think there's a strong foundation built, and I just want to keep building upon that foundation. Next slide, please. Thank you. So I want to describe the team that they will be building in some of our work streams. So I was brought on to help develop and mature our research and data capacity to support the MPA. The MPA provides so much opportunity in terms of research going forward, but I think it starts with building this team up. And right now I'm a one-person shop, but I'm hoping that's going to change quickly. Over the next couple of quarters of this year, I'll be staffing up. I'll have the capacity to bring on a few team members. And the team's going to be mixed in terms of experience. So I hope to have an experienced researcher that I can lean on to discuss strategy, vision, research, who can kind of help me coach up the less experienced research staff. I think there's value in having a team structured in that way, with room for growth for those junior researchers. And I'm going to be focus on building an environment of collaboration, trust, knowledge sharing, and providing the team with the support they need to succeed. In terms of skill set for these staff members, I think both hard skills and soft skills are very important. For hard skills, something like Tableau comes to mind. A lot of the work that we do is around data analytics and using data to create visualizations. So bringing on folks who have experience with Tableau or the capacity to learn and experience with analytics is going to be really important. But just as important are those soft skills. And I think folks that are curious, folks that want to use research and data to drive policy, folks that are able or interested and able to present research findings to a wide variety of audiences. That's going to be critical because it's not easy to present kind of complex, nuanced research findings to a wide variety of audiences. So I'm going to be working hard on building up this team and hope to have updates for you at upcoming partnership meetings. So I'm building up this team to support a healthy portfolio of work, and I've listed some of our work streams and types of work on this slide. I think supporting this partnership is going to be critical. There's so much opportunity here and so much work ahead of us. I consider that this a primary work stream for my team. Supporting in terms of helping identify priorities, helping to acquire data sets, engaging with the work groups, discussing research methods, removing roadblocks, however else we're able to support this group. The data dashboard for aging, or the DDA, that's another critical work stream. I want to give a shout out to Terry Shaw, who I think most of you know, and Terry's been an invaluable resource for me in terms of helping to onboard me, being there for every questions or thoughts I need help fleshing out, half-baked thoughts most of the time. And Terry and our partners at the Department of Public Health and West Health have done a great job standing up this data dashboard for aging and bringing in many valuable data resources. So I hope to build upon the good work that they've done. Eventually, the DDA will be something that my team will maintain in-house. We'll be collaborating with partners to bring on more data in developing visualizations. Research and evaluation is going to be critical, obviously. The way I'm viewing our research in the near future, at least, is collaboration with our partners. I think initially our research will be focused on partnering with stakeholders, you all, as opposed to conducting independent research just within CDA. I think we have great partners and resources, and we should leverage those resources. So partnering to discuss research concepts, data sets, methods, all of that fun stuff. And CDA data management and data sharing. I think there's a lot of important efforts that are being undertaken in-house regarding maturing our data management systems. And my team will be partnering with our IT team to work on these efforts. In regards to data sharing, kind of looking ahead, we want to ensure that we have good relationships throughout the state to acquire data, but also provide data when necessary. Then finally, partnership engagement. I think I've mentioned that several times already. We're going to be working closely with you all and our other stakeholders, and it's a critical priority for us to maintain good relationships and keep this work moving forward. Next slide, please. This last slide to describe the stakeholder committees that the CDA supports. The research partnership obviously being one of them. And these committees all play important roles. And I think it's going to be critical that we are all communicating, especially for us, because data and research touches everything. One of my roles is going to be working with my colleagues to ensure that we are communicating and providing these groups with updates from our efforts and vice versa. And I may tap into some of you periodically to provide updates to these groups, or asking other group members to provide us with updates. So that was a lot of information. I'm going to pause here and open up for any questions or comments you may have. I think we have a few minutes for questions and comments. So I'm not seeing any, so we can go ahead and move on to the next agenda item. So the next agenda item is around our CADP subcommittee overview and providing updates. And you can go to the next slide, please. I'll open things up and I'll hand it off to our team members. So I thought it would be important and helpful to provide some context on the different tools that we're utilizing to track progress of the MPA. There are several different tools. It can get a bit confusing. And I sent out a document yesterday which describes these tools, and I'll touch on them now. So we have our data dashboard for aging, which most of you are probably familiar with. The DDA kind of serves as a central source for data around the MPA. There are visualizations related to the respective initiatives and strategies for the 5 goals of the MPA. It also includes an indicator progress dashboard, which displays data on key indicators and includes statewide trends. And the goal of this dashboard is to show change over time related to the key indicators. There's also the demographic dashboard as part of this DDA. It's a statewide profile of older adults in California, includes many different variables such as SOGI, race, ethnicity, household size. The DDA is an effective tool for folks that want to access data quickly related to the populations that the MPA goals are targeting, and it's a centralized location for many different data. The MPA implementation tracker, which Sarah described earlier, that's a tool which allows users to search for progress updates by goal, strategy, initiative, topics, among other filters. Then finally, we have the key outcomes, which are formerly known as beacons. And I think the concept of beacons were introduced last year, and we're just calling them key outcomes now because that seems to be more widely understood. And these are longer term outcome measures that cut across multiple MPA goals and include several parameters. And I think the charge of this partnership group at this point, and we'll discuss further when we discuss the work plan, is to develop these key outcomes, and we'll leverage the respective subcommittees or different work groups to flesh these out. And so I want to elaborate a bit further on these outcomes. So we can go to the next slide, please. Thank you. As a reminder, these are key outcomes work groups and their respective members. If you're interested in joining one of these work groups, please let myself or one of the leads know. And these folks are meeting outside of these full partnership groups to flesh out ideas and concepts and discuss data sources, things of that nature regarding key outcomes. As you can see, the subject area is centered around housing, homelessness and transportation, behavioral health and isolation, and the paid and unpaid caregiving workforce. So the key outcomes will tie to these topics which support the MPA goals. I think for now we plan on elevating up to 5 outcomes total across these 3 work groups as key outcomes. Next slide, please. Thank you. This might be a refresher for some of you, but these were some of the parameters that were discussed previously for the key outcomes. And we'd like to have these parameters for each of the key outcomes. So I'll go through each of these parameters quickly. So each outcome will have a goal, which is essentially the key outcome, and the drivers, which would include the different interventions that drive progress towards meeting that goal. And we need an indicator that represents both the outcome and the respective driver, and that this is going to be a metric that we can measure towards progress. What factors should be considered? This could center around, demographics of the populations we're targeting, economic factors, et cetera. What's our target? An example would be we want to see X% reduction by 2030. Data sources, which are critical, but also data gaps, which can be just as critical. Understanding where the data gaps are can help us understand the scope of our outcome, and also if it's feasible to try and collect those data. Then finally, research gaps. What research and what types of research is needed to inform progress? Is there similar research out there? We obviously don't want to duplicate efforts. Next slide, please. Thank you. I've been discussing the concept of key outcomes with Terry, and Terry was gracious enough to develop criteria that can be used in selecting key outcomes. There was a criteria document that I sent out yesterday as well, but this slide displays those criteria. So we want it to be goal-oriented. The outcomes should be directly related to at least one of the MPA goals and offer optimal opportunities to achieve these goals. Policy aligned. The outcome should align with key policy priorities. And as the work group fleshes out outcomes and discusses with CDA, we can help provide direction there. Equity promoting. It's very important that the work we do drives equity goals and targets progress for underserved communities. Achievable. The MPA is a 10-year plan. So we'd like to align these goals to that timeline, and meaningful. And these outcome measures are important and should have a meaningful and positive impact on the well-being of older adults, people with disabilities, and their families. Next slide. Thank you. So this is a key outcome example that was previously developed. And this one is around ending homelessness for older adults and adults with disabilities. And a possible driver to achieve this goal could be increasing targeted rental assistance. This example includes an indicator for both outcome and the respective driver. It's something we can actually measure, right? So that's really important. So on this one, the indicator is the number or percentage of adults age 50 plus and adults with disabilities or homeless at a point in time during the year. The driver indicator could be the funding or the percentage of total rental assistance delivered to adults age 50 or older with disabilities, and or the number or percentage of adults 50 plus and adults with disabilities who are severely housing burdened. The factors in this example include many different demographics. It also includes a home ownership status, rental versus owned. The target here is X% reduction by 2030. Data sources, annual point in time counts, or the ACS, and data gaps, demographics of unsheltered geographic data, then also demographics of the severely housing cost burden, and the research gap would be something that the group would need to flesh out. So I hope this information is helpful as the working groups kind of work towards developing these key outcomes. And we'll discuss further when we discuss our work plan. And I'm going to hand it off to the respective work group members to provide us with updates. And after that, we may have time for questions regarding this topic. So Zia, may I hand it off to you to start with the updates?
Thank you so much, Ross. First of all, thank you so much for setting the stage. You did a great job explaining, the framework of the key outcomes, and then also the rubric that we're going to use to help identify or select them. Do you have the slide deck that I had sent to you? I want to just quickly go over, not in too much detail, but some of the work we have done with our subgroup between our last meeting in December and this meeting. So,
So yeah,
Ross, do you want me to share my screen or?
I don't know if I received that slide deck. So if you have the slide deck up, if you don't mind sharing your screen, please.
No worries. Let me see. Share screen. Okay. Can you guys see a sort of like an orange and blue tree? Can you see a slide?
Yeah. Yep, I can see it.
Okay. Okay, so I'm going to report back, and there's three groups. Yeah, there's behavioral health, there's the caregivers group, and I know Terry, you're going to provide an update for the group that you and Dr. Lindemann were working on. David's on a flight to Europe right now. But I've been working with our team internally and then with our subgroup to really help flush out what could be some of the key outcomes under behavioral health. And we've come up with sort of three big key outcomes. And I'm going to walk through those and give you examples. Of course, this is work in progress, and there will be some data challenges that we will face in the future. But we landed on three areas. One would be the big outcome of increasing the experience of well-being from a behavioral health perspective. So it's a much more person-centered and person-focused outcome. And within that, some of the areas, whether you want to call them drivers or indicators that we are thinking of, are things like increasing the number of older and disabled adults who report community support, reducing loneliness, reducing psychological distress, increasing life satisfaction. And most of this type of data will be coming to us from surveys. CHIS is a good example of that survey. Of course, Catherine Kitzman is working with us in this subgroup, and her leadership and her understanding of that data resource is going to be critical. But there will be other sources that we're looking for. So if folks have ideas of data that can help us understand some of these areas, indicators and drivers, we would love to include that. The second big area is more what I would say around services and access to services. And so there, the big key outcome is, can we increase access to behavioral and mental health services? As we have seen both through COVID and even before that, a big barrier in our state and in most states is just having access, both in terms of providers or insurance or affordability. And so how do we address that? And we're looking sort of holistically along access barriers. One way to measure that is to sort of understand what are some of the unmet needs at the population level. And there is data sources like SAMHSA that collect that data and can help you quantify what percentage of your population has an unmet behavioral health need. The other way to look at it is to look at how many behavioral health practitioners or providers are available per 1,000 population or 100,000 population that are either providing that service, but also for us, importantly, are participating in some sort of a publicly funded insurance program, Medicare and Medicaid. Increasing access to virtual care. We've seen through COVID that virtual care has become a very important aspect of healthcare delivery, and especially for people who are in remote areas or for seniors where travel can be a burden, or folks with disabilities where travel and going to see the doctor can be a burden. What is the uptake and adoption of virtual care services? And we hope to, one option would be to hope to model that and measure both access in terms of who has those services and then what's the frequency of usage. There's some great work the state is leading on crisis care and emergency care through the GED initiative. So we want to leverage that to really understand when seniors and people with disabilities have a crisis, a behavioral health crisis, where are they getting services and what services are available to them, and can we increase those? Can we make those better? And so that's the next one down here. And then cognitive care. Yeah, we've talked about dementia, where of course cognition and behavioral health go hand in hand. And so I think another indicator or driver could be increasing access to those services for older adults and folks with disabilities. And then the third area, which of course will overlap much more in detail with the larger discussion around workforce, but we think that a critical piece of this, or the third leg of the stool, is really improving the workforce. Yeah. And that is not just about increasing the numbers, but also increasing training and providing better resources to both paid and unpaid caregivers. And so you could imagine a key measure or a key outcome could be the increasing the behavioral health workforce knowledge, staffing, and support. And within that, there could be things like addressing behavioral health workforce supply challenges, producing more informed caregiving workforces. So this is where you can have training programs specifically focused on behavioral health, and provide support to family caregivers. Taking care of somebody with serious mental illness, taking care of somebody with dementia is a huge responsibility and a huge burden sometimes on family members. How can we support them? So this is a quick sort of overview. I don't want to spend too much time today, but we'll be working with all of you to sort of refine these domains and indicators and key outcomes. And just want to demonstrate the progress we have made to date. I'll stop there, and we can of course take questions after our next subgroup gets to present. Ross, do you know who it is?
Thanks. Yeah. I think this is me, Bella. I'd hand it over to you, Bella.
Awesome, Bella.
Great. Let me just pull my slide up here. Oops, can I get this? And I have a very short presentation. All right. Hopefully this will work. Can everyone see this?
Yeah, I can see it.
So I'm just going to give an overview. So Zia just gave a fantastic kind of presentation on how these research groups kind of think about this. And I'm just going to give a brief overview of the consortium generally and how we've been thinking about it. So we do have the 5 key outcomes. We're starting with 3. And usually how consortiums build is you do some pilot work, you publish some good papers, and assemble some good data, and it generates buzz, and then it sort of brings a consortium together and they kind of coalesce. We're starting with a slightly different approach where it's more, we have a more clear idea of what we're doing to begin with. So the overall PI is Ross Alian. He's directing sort of the direction of the research, identifying the key outcomes and kind of directing the whole thing, with David Lindemann at Citrus, kind of co-directing that. David is leading the research. And within this, there's several cores or several groups of stakeholders. One is data management. We've already heard about the amazing work done by Dr. Aga and his team at West Health, assembling the dashboard. And underlying that dashboard is a collection of data. So there's really 2 kinds of data you can use for research. There's sort of publicly available data, aggregated data, indicator data, and the dashboard contains a lot of those kinds of data. And then there's microdata, which is being assembled by the data management core at CDII. And the vision is hopefully to be able to integrate both of these data types to answer important questions around the key outcomes. There's stakeholders, for example, agency stakeholders. So, and again, CDII is going to talk more about this, but they have interests and concerns around how data are used or programmatic priorities. So we want to always be keeping those things in mind. And then the consortium, within the consortium, each subject matter area has a PI who's really leading the work, identifying pilot projects that we can do to answer questions around these key outcomes. And then under each consortium PI will be research staff, doctoral students, postdocs, things like that. And then as the consortium grows and as data assets are assembled, we expect sort of a natural and organic outgrowth of people applying for grants and identifying additional academic collaborators. So that's sort of the vision. We're very early days right now. I would say we know who the leadership team is. We know what our key outcomes are. We're assembling our teams and we're identifying, kind of at the data landscaping point where we're identifying which data sets we can use to answer these questions and where there are both research gaps and data gaps. So that's kind of the vision of the consortium. If there are any questions, I'm happy to answer them. And if not, I'll yield the floor.
Thanks, Bella. I don't see any questions.
I would love to just chime in here. Thank you. That is a wonderful overview, Bella. And I'm super excited about, this was a concept that was raised by the research subcommittee when we were in the process of developing the master plan for aging. And we thought it was kind of a pipe dream, but the fact that we're actually talking about how we would operationalize this sort of a research consortium, and I love how it's aligning with the work of the key outcomes, is very exciting. I think the big next step will be figuring out, as we flesh out the concept, where we might find some initial resources. So that's something that we're going to be working on. And, I know that where there's a will, there's a way. We can just keep thinking of different pathways forward, but really appreciate you all helping us think about how we might roll something like this out.
Thanks, Sarah. I think, Terry, you're going to step in for David to provide the next update on the subcommittees.
Yes, it is definitely an honor to be able to fill in for David while he's traveling. I just have a few updates to share from some recent conversations that some of the subgroup members have been engaged in, particularly Donna Benton and Nari Ree and David as well. So the group of us have met to begin brainstorming ideas for key outcomes and related drivers and indicators in the workforce and caregiving space. I think we quickly realized that there's a lot to be mined here, and so we'll need to be working on an ongoing basis. So we're working on setting up a schedule of ongoing messages. But the goal there is then to be able to build out recommendations about these key outcomes and drivers and related indicators to make to the full partnership, all of you, and to the state. So some initial thoughts that came up in our discussion so far, obviously on the workforce side, there's a lot of synergy with what Zia was noting. Some of the discussion we've had centers on first building on the good work that's already been done in the workforce space by Heather Young and many others, and that's continuing to be done, and trying to leverage that for purposes of identifying the key outcomes in the paid workforce. So in alignment with that, then we would imagine that some of the key outcomes would, of course, relate to the numbers of specified types of providers relative to, or as a proportion of, the population of older adults, including particularly a focus on those 80 and above, because that's where we think there's potentially a lot of need and a lot of equity concerns. And also, of course, to look not just at older adults and older adults above 80, but also people with disabilities and chronic care needs across the adult age spectrum. So some of the related drivers that we talked about included things like, of course, wages, availability of training programs, and also trends in recruitment and retention. So these are all candidates that we have started to identify. And the group is really interested in providing both near and long-term targets for improvement. So not just outcomes and goals broadly stated, but specific targets for near and long-term. On the informal caregiver side, again, there's work to build from. For example, we have a set of indicators already in the data dashboard for aging about family and friend caregivers, which draw on data from the California Health Interview Survey, and thank you to Catherine Keatsman and her team for that great work, both on the data collection and on helping us put the indicators into the dashboard. Appreciate that. So that's a set of candidates that we can consider. And so based on those and other data, we'll be identifying key outcomes and related drivers. And one of the things that we'll be looking at is, as has been mentioned in some of the earlier conversation already, data about paid family leave, because we know that that is an important component of the, or has the potential to be an important component of the support for family and friend caregivers. So that's where we've gotten so far. Really encourage others to weigh in, join the conversation. All of these subgroups, including this one, are open to all of the CADR members, so research partnership members. So please, if you're interested and would like to join, we'd be happy to have you. And I don't know if Donna or Nari wanted to add anything else, but I think we've got it. Okay.
Thank you, Terry.
Wonderful.
I do want to add one more thing that's really important. Last week or maybe the week before that, myself and David were able to represent the CADR team and our committee in a presentation with the equity committee and the equity work group. And there was tremendous appreciation of the work we are leading. And there was also a request that we include measures that will address equity across all of our measures of outcomes and indicators. And so that's an important thread that we have to weave through everything. And we'll be engaging with all of you to help guide us to make sure we do that in an appropriate fashion. Thank you.
Thanks, Zia. Does anyone else have any questions or comments? We have about a couple of minutes if anyone else wants to chime in about the approach to outcomes or anything else. And again, we'll talk about this later, but CDA, we want to be here to help kind of facilitate these meetings. I know y'all are extremely busy, so we want to help out in any way we can. Janet, I see your hand raised, please. Not a say, okay, sorry, I thought I say raised hand, but. Okay, so if there's no other comments, we could go to the next agenda item. This is a really exciting agenda topic. It's about an LGBTQ study that we're getting ready to undertake. Kathleen Sullivan, who's the executive director with Open House, will walk us through an introduction of this project, why it's important, what we hope to accomplish. Before I hand it over to Kathleen, I just want to voice our excitement about this project. This type of project has not been undertaken in California before, so it's meaningful, it's innovative. It has a potential to do a lot of good, and it's something that we can replicate and conduct on a periodic basis. So I think it'll serve as a really good example of the types of research projects we should be exploring. So with that, Kathleen, I'm going to hand it over to you. Thank you.
Great. Thank you, Ross. It's great to be with all of you today. Open House, which is where I am right now and where I'm the executive director, is an organization based in San Francisco that provides housing, services, and programs for LGBT older adults. You can go to the next slide. Thank you. So I just wanted to show, go back one. There you go. Yeah, I added this slide because, who are we talking about? I think it's really important to really humanize who we're speaking of. These are LGBTQ plus Californians are oftentimes older adults in this group are the most marginalized in our community and grew up in the most homophobic and transphobic time in our nation's history. So you can go to the next slide. Oh, other way. There you go. Okay, super. The estimates vary in terms of the size of this population. There's no list of who is LGBT in the state or anywhere else across the country. The census does the household pulse survey, and that has found that California is home to 2.7 million LGBTQ older adults, and that is the largest population of any state across the nation. So you might actually consider that, that's not very surprising, but perhaps what is surprising is that 9.1% of older adults in the state identify as LGBTQ. We don't have data, as Ross just pointed out rightly. We've never done a baseline survey to find out what is the aging experience for this particular group of Californians. We do, however, know from national data a few things that I'll share. One is that nationally, LGBTQ older adults are more likely to live alone than the general population of older adults. I believe my memory serves me correctly, in Los Angeles, 58% of LGBTQ elders in LA County live on their own. 2/3 self-report that they do not disclose their sexual orientation or gender identity in long-term care communities. We've seen time and time again higher rates of self-reported disability. Marcy Edelman, who was noted earlier, did a study in San Francisco that found that lesbian and bisexual women actually have the highest rate of self-reported disability, but we see a lot of comorbidity within this community across the board. And then a study done in San Francisco during the pandemic found that compared to pre-pandemic numbers in terms of mental health and depression, rates of depression, LGBTQ elders in San Francisco were really suffering higher rates of depression, isolation, and suicidal ideation. You can go to the next slide. Thank you. One more. There we go. Great, thanks so much. So as of yet, we have no statewide data, as we have pointed out, on the aging experience. And that just means that, for instance, we don't know what is the aging experience for long-term survivors of HIV/AIDS. Those folks oftentimes have, obviously they're living with a chronic disease, but there are more comorbidities brought about because of the disease. And often sometimes we believe because of the drug therapies that folks have been on for 20 plus years. We have no data statewide on what the aging experience is for transgender Californians. So what is the access or barriers to care and service for that group? And no data, of course, on what the impact of COVID-19 has been for our BIPOC, API, LGBT community members. We do have some anecdotal information, and as many people know, the AAAs in their planning surveys have included SOGI data, which is great. So there's some local research, but still no statewide picture of what is the aging experience for this community. So that's why we're proposing to do a study. So you can go to the next slide. Thank you. We're proposing to do a community-based study. This is based on a model that was used successfully in Oregon. I was very proud to be part of that, a very large group that put together that study. It included really leveraging the resources, both of the community as well as the state. And that leveraging of the statewide coalition of community organizations was really vital to ensure that LGBT community members felt safe taking the survey. So it was something that trusted voices were used in the community to get the survey out to a variety of different communities. Of course, our wonderful California Department of Aging has provided national leadership with the Master Plan on Aging, but also I just want to point out and thank again is showing great leadership on really embracing the idea of doing this type of research project. And our goals simply are to develop this baseline information so we get a better, a broad picture of the health, the economic stability, and well-being of older LGBTQ residents of California in order to identify some service gaps, the challenges for our BIPOC API elders, as well as rural and frontier elders. That's something that we found in Oregon was really vital to understand what the barriers to access to care and how far, for instance, people were traveling for healthcare. But we want to highlight as well some priorities for service and then provide a research model for the department moving forward. The next slide, please. Thank you. And I'm working with David, obviously, on this. But key components of this study are we're creating a statewide coalition, as I said, of service providers that can be LGBTQ centers, local and state agencies. So our AAAs will be great partners for this. Obviously, the Department of Aging, Open House, where I work, Leading Age California has been very interested in being supportive and very active in helping with this research study. And there are other organizations, you can read that, I don't have to read it for you, but you know, we do have a very robust dementia care network in Northern California through the Alzheimer's Association and other local LGBT organizations. The survey will be informed by not just the coalition members, but also creating an advisory committee. Some of those members will be suggested by our statewide coalition, and some will be researchers in the field and other folks perhaps by the California Department of Aging who they believe need to sit around the table to make sure we get the best instrument possible. The survey will go in the field. It will be an online or a paper survey. In Oregon, using that example, we had 1,400 people take the survey. All but one of them did it online. But we want to make sure that we're not playing into the digital divide. So there will be paper surveys available as well. And we're looking into how we can fund translating those surveys so that folks will be able to participate. And then presentations and report outs will be part of the overall plan so that we're not simply taking information out of a community. We're going back and explaining what does the data say? What can we tell you generally about where you live? Next slide. Thank you. And so really this entire research project is something that we hope is living and evergreen and is used to expand training opportunities in healthcare or other aging networks to better understand and reach older LGBT folks, improve access to care and services, and recommend or have recommendations for priorities for public and private programs, interventions, policies that perhaps we want to look at and implement. And it's very important to both the California Department of Aging and to me as someone that was working on this project or working on the project in Oregon, that this really is open source data, that this is something that can be on the dashboard of the Department of Aging, that researchers in the state can access to sort of tease out more information to basically help us get a better, more sophisticated view. And then the hope is that we can keep the committee, the coalition together so that it also will be more like a policy working group and collegial statewide coalition to work on whether it's policy or for, in 3 to 5 years when the Department of Aging decides that it's time to revisit some of the questions that were posed in the original baseline survey. We have that coalition that's still up and running, so it's very easy to re-implement the survey. So it's a great opportunity. We're very happy to, Open House is very happy to be a very small part of this program, and I'm happy to answer any questions that folks might have.
Thanks, Kathleen. If anyone has any questions, just please hop right in, raise your hand.
Well, I just want to add in, first, thank you, Kathleen. You did such a great job of kind of outlining the importance of this effort and how to proceed and why it's so critical to planning for the needs of the older adults who identify as LGBTQ. For us, this is a really exciting opportunity because this is an area where we really have a dearth of data, and I think it could provide us with some really key data that outlines where the needs are in the system, and that can help inform planning at the local level through our area agencies on aging and other service providers. I think the big challenge, as you've noted, is how we can develop kind of a sustainable way to keep this data on a longer term basis, but at least starting with one point in time, I think is a great first step. So what's also really important about it is this is very intersectional. This is also a priority for our equity in advisory committee in aging and disability. So they will be providing some key input as well. And I think at this point, we're just excited to get the resources tied together so that we can begin this effort, and we'll look to all of you for your engagement throughout. So.
Great, thank you.
Yeah. Okay. Kathleen, I want to just second everything Sarah just said and let you know that be happy to help distribute the survey down here in San Diego.
Fantastic. That's great.
Thank you, Kathleen. Awesome presentation. I appreciate it. I don't see any other questions, so we could move on. Our next agenda item is about the Agency Data Hub. Our partners from the Center for Data Insights and Innovation will be walking us through this topic. And Simi, I think I'm going to hand it over to you.
Good morning, Ross, and thank you so much. It's a pleasure to be here. And just like what you mentioned, I am as well new to the Agency Data Hub, being the chief for data and engineering, just joined CDII, and it's such a pleasure to be a part of this community and looking forward to working with all of you guys. Just wanted to mention about Agency Data Hub. You heard a little bit earlier from Elizabeth, what she alluded to. So the mission of California Health and Human Services Center for Data Insights and Innovation is to help support and shape the agency's internal data strategy and improve the lives of Californians by turning data into insights in knowledge and action. And the vision is to support programs that are person-centered, equity-focused, and data-driven, just like all of you guys, all of the team members that spoke about today. So I think it really fits into that, and that's what the Data Hub is. So today, what I'm going to do is just going to give you a very short introduction, just like what Bella had mentioned. It's just a high-level introduction of what the Data Hub is. And I'm sure we'll have future opportunities to talk about more of the framework, the details about the technicality and all of those. But today I just wanted to today I wanted to introduce the journey of what we are into. With that, can I have the next slide, please? Yes, so let's start with the why. So why are we doing this, right? So it is basically to reduce the time between having a question and the right data to answer it. And having the right, and from all the pain points that we've heard about, being data in silos. And also to reduce administrative burden for both departments and data requesters. That's some of the other things that we've heard about. Followed by streamlining process for departments or data requesters. So these are some of the main whys that we have to work with in getting this Data Hub together. So it's a traditional program-centric design of statewide data use. We have a barrier of how programs are siloed, and we are looking into more of how to bring that together. So the Data Hub, for short, the Agency Data Hub, we call it Data Hub in short, will deliver on CalH's guiding principle of using data to drive action. So with that said, could I have the next slide, please? Let's touch a little bit about the how, and this is by creating a unified process across CalH's department to use data for research. And just to talk a little bit more about why unified and focused, right? That effort is so critical when we're working with data to deliver integrated data analytics capabilities required for various research requirements and how current it is. So that would be the main focus. Now moving on to, next slide, please. So with all of the why and the how that I mentioned to you guys, to the team here, how is it we talked about? Now, what are we using to bring that together? And that is the Agency Data Hub. And in brief, it is an ecosystem that we are building of cloud-based platforms and services for sharing data and streamlining data requests. So with the Agency Data Hub, what happens is the CalH's partners and authorized external researchers can securely access an isolated or virtual workspace to study and analyze confidential data across different programs. And access to a project workspace is strictly limited to users with authorization to lead the project workspace. And this is what Elizabeth alluded to earlier on some of the use cases that we have already gone through. And I think in the past sessions, those use cases have been introduced. For example, the all hazards dashboard, the equity dashboard, these are all use cases that are currently happening within the Data Hub. Now, just giving you a little bit more insight about what this is. Could I have the next slide, please? So this is how this is a very high 30,000 feet view of what the Agency Data Hub looks like. So literally we have the data sources and how they come into the Agency Data Hub, which is a combination of the Data Lab with the Databricks and AWS. along with a secure enclave in combination with the administrative data research facility that we are getting to work with the ADRF, and how that can be converted into data outputs. Where you see on the right-hand side, where any of the departments can use the existing tools that they might have, like the Tableau, the AGOL, data systems. Any of those could be used, right? And then we have the data consumers, which is a main attraction where external researchers and state data analysts who will be able to go into and perform the required research that can happen. So this is in a very, very high level, 30,000 feet up, just to get our journey started, right? On what the data hub is and how we all can come together as a community and make use of this. And with that, I think I can pause here and take some of the high-level questions that you might have. Otherwise, I'm really looking forward to this journey together.
I had a question, Simi. So the authorized external researchers, can you speak to that process at all? Like, how do you become authorized and who's authorized, et cetera?
Yes, and we are working on the whole authorization part of it, how we can have, whether it is through a common portal or how it's going to happen, like a data request management that would happen. And from Elizabeth can probably give a little bit more highlight about how the data request management would happen. Elizabeth, are you there or?
Yes, hi everyone. So absolutely, and I want to call out that we are building the data hub in phases, right? So what Simi pointed out with the equity dashboard and the all hazards dashboard, right now those are leveraging the agency data hub, but not the secure enclave, right? So the secure enclave is the next phase. It's in development now, and so we're not right yet at the point where researchers are going to come in and use that system. It's a little bit complicated. Everything in the state is complicated when it comes to data, right? So what we're looking at is we're coordinating across departments and also with CPHS, which is of course the Committee for the Protection of Human Subjects, to see how we can create a streamlined request system. So as the data requests come in, get authorized, can that data, once approved, be transferred directly between the providing department to the secure enclave, and then for that same process to identify who is an authorized user from the external researcher perspective. So this is really in its beginning stages, but it is part of the whole vision. And so does that start to answer?
That helps. Yep. Thank you, Elizabeth. Appreciate that. There's a couple hands. I think Margot had her hand up first. You want to hop in, Margot? Thank you.
Sure. Thanks so much, Simi and Elizabeth. Super exciting. I'm wondering what you envision as a possibility to merge HHS data with other state data, because that's in some ways where the real power comes in with DSS data, even county level or state level data from other programs and services across state government that don't sit under HHS.
Yeah, definitely not ruling out any of those combinations or collaborations that we need to do. But I think we are doing it in phases right now, Margaret. So basically getting started, having that small use cases, we call it the minimum viable product, right? So we want to make sure that that is functioning, like what we want to see, right? And then we will be looking into those possibilities of how we can bring other external data or, what process that we are implementing right now is getting it started in small steps so that we are moving forward using the minimum viable product process. So to answer your question, long term, definitely we will be looking into something like that. But right now, we're very focused to get that rolling out in small phases.
Thank you.
Thanks, Simi. I think Bella had a question.
I think you're on mute, Bella.
Just want to express my excitement that this is happening. I've been talking to Emily Putnam-Hornstein and Reagan Faust for a long time, and they've been telling me that this is in the works. So really neat to see kind of the vision. And I just wanted to second Dr. Kushal's comment that combining health data with other external data, that's really where you get the exposure side and the power of these data. Do you have a sense of the timeline before that sort of combination may even be like before someone could say initiate a pilot project combining like, are we looking at 5 years, 10 years, 2 years? Just a sense of, you know.
Great question, Bella. It's like, just like what I said, it's like month 2 of me here. So I'm really looking into things that we can take forward. Definitely take it back to our team, the interests that you guys are mentioning about and see where we can go with it. But to be honest, I do not have a plan on when that is going to happen. Yeah. But just looking forward to feedback like that, right? And I think that's where we can grow together and bring this journey, right? Where it can be really not a siloed effort of people working on bringing that whole holistic view, the person-centered view that we're talking about, right? That's what's missing today in research, I think.
Thanks, Amy. I don't see any other hands. Oh, Zia, you have your hand up. I'm sorry, I missed that.
Yeah,
ahead,
I was just going to offer again my congratulations and what a beautiful thing you guys are trying to build. Maybe there's an opportunity, Simi, to like do some small again, like a pilot that can be a use case, like you were saying, with our committee, CADRP, that sort of demonstrates the ability to combine data. Yep, and it could be a very small scale effort, but it'll at least prove it out. So we'll follow up with you.
Definitely, and just like what I said, I can't begin that journey, right? But it's just that we need to be cautious because we are dealing with data just to make sure that the right thing is happening. So baby steps, but definitely, but I think larger things are in the vision. Thank you, Zia.
Thank you, Simi. Appreciate it. That was a really helpful conversation. Hope to continue that going forward. So I had a break built in after this, but we're flying by with this agenda, and I think we can just power through. So we can go to the next slide, please. So the next agenda item is a member discussion regarding the work plan and priorities for the coming several months. I welcome discussion here. And that's kind of the purpose of this agenda item. So please hop right in, raise your hand, use the chat function. Next slide, please. So I thought we could start this discussion by thinking through some of the priorities, and we discussed key outcomes earlier this morning. And so what we're proposing is elevating up to 5 outcome measures as key outcomes total across the 3 respective work groups. And so collectively with CDA's input, we can prioritize, the 2 to 3 outcomes possibly that these work groups come up with. And we can all prioritize that and kind of determine which 5 up to 5 outcomes we want to elevate and kind of focus on. So I'd love to open up to the group and hear from the respective work groups and other folks on what's your thoughts here. Does it sound reasonable? We have plenty of times we can even use this time to kind of flesh out some of these key outcomes if that would be helpful. So I'm just going to open up the floor here. We'd love to hear from you all. Does that sound reasonable? So from whether these work groups that come up with maybe 2 to 3 different outcomes, then discuss it with CDA and we could help prioritize up to 5 key outcomes.
No, I think that's right, Ross. I think we're sort of at the stage right now where we are more, I would say, in the exploring phase. We need to then very quickly start to prioritize based on the criteria that you had so nicely presented. Yeah. And then we can recommend within each of those 3 areas, 2 or 3 high value outcomes to CDA and to this committee. We can also share with, offline the slide deck or the sort of the work we have done so far with the larger group to get more input.
Thanks, Zia. Okay, that would be really helpful. Share the slide deck.
I'm also curious, I just want to say, Margot, it's so wonderful to have you here. Given your tremendous leadership and expertise in the housing arena, and I know that's one of our kind of key outcome areas is both housing and transportation, but for the housing area, Ross put up a kind of a straw proposal for how we could approach it. And I'm curious about your thinking on that and how we advance our work in really developing outcomes that are meaningful that can be measured and with any benchmarks as well.
Yeah, I mean, first of all, thank you so much for inviting me. I'm sorry my schedule is so nutty that I missed too many meetings, but I'm thrilled to be here, thrilled the emphasis on housing and homelessness. You know, the reason I think I just asked the question of see me and things is that there is a lot of potential in the state to do really incredible work on this. Our problem is usually the data mergers. The point in time count is quite limited because first of all, HUD does not mandate collecting. They do basically 25 to 64 and 65 and up. And actually most of the action in the aging population is 50 to 64, because unfortunately people, they age earlier, they have the aging related disabilities by the time they're 50, but they died before they're 65. And so it's, the action is right there, and HUD doesn't mandate it. A lot of COCs collect the data, but don't publish it. But the really exciting, but there are lots of problems with the PIT. The really exciting potential is that the state has now gathered all of the HMIS data, Homeless Management Information System, which is mandated by HUD. Each COC or continuum of care collects anyone interacting with any homelessness services, basically who receives federal funding, to be registered in that. Imperfect, but it has much richer data. And our team, through a project we're doing with the Turner Center of a Landscape Analysis of State Programs, has actually delved into the HDIS data, and there's a lot of potential there. But I think the key is the real benefit is to be able to use that data in flexible ways. And I think there's just been some data issues that are sort of getting that up to ready to use. I think that I think looking at inflows into homelessness at that age are incredibly important, because what we know from my research, others, is that about half of the people who are 50 and older and homeless are newly homeless after the age of 50, meaning they've never been homeless before. And there's a lot of prevention activity. I think trying to get a handle on better targeting prevention activities, meeting the needs of that population, looking, I think the other really key thing is I sense that we are institutionalizing a lot of folks who could live in the community, because when you're homeless, you know, you're either stay homeless or you go into a SNF. And so I think that is like another key outcome, is to look at entries into skilled nursing facilities of people who could actually live in the community, because that is, I think, reflects sort of a conflation of not having housing and not having home and community-based services really adapted for this population. So I guess I'm thinking along inflows into homelessness, outflows into homelessness. HDIS is going to be the best way to look at that in this population. I think we should look at use of home and community-based services, which has been I think a gap in this population. And I think the state would have a big interest, and I think we would all have a big interest in looking at entries into nursing facilities for people who entered homeless and are sort of young, right? And with adequate housing and home and community-based services could actually avoid nursing home cares and thrive in the community. So those are just a few things that I feel like could be really important things to look at, and I would be interested in other steps.
Thank you, Margot. That was really informative. And as we flesh out these key outcomes, we're also going to partner with other state.
Ross, before you go on, just one more to build on what she was saying. I think another source of data would be what Department of Healthcare Services is learning through their PATH project, which because a number of providers who are offering that service are going through real changes and struggles in terms of managing the number of beds and the ability to continue to provide those services. So there's something there in terms of what's working and not working as we're going to continue to build and try to create something more effective.
Thank you, Steve. Appreciate that. Does anyone else have thoughts on data sources or anything else around this work group or the other two work groups?
It looks like Dr. Wilbur has her hand up.
Thank you. Dr. Wilbur, please hop in.
You're on mute.
You're definitely on mute.
Definitely. I'm so sorry. So first of all, just let me say how incredible and informative this whole morning has been. I want to throw out something that's more macro, and maybe you already do it and it's not necessary. But I participated with a colleague who did a policy scan of comparing policy outcomes in 3 states related to COVID, and thinking about if the major goal is data-driven legislative decisions, tracking those legislative decisions. So what gets introduced, what gets passed, how does that relate to the recommendations that come out of the data analysis that different groups are doing? So with LGBTQ as a pilot, does that then lead to the introduction of legislation? Does that what gets passed? How does that translate into sort of programs and policies? And so kind of closing that loop. I learned a lot about policy scans. I thought, you just do it, but this colleague really helped with a pretty systematic approach. So I just wanted to throw that out as something to think about.
Thanks, Dr. Wilbur. This is a really good idea. I thought I saw Bella's hand up. Do you still want to chime in, Bella?
No, I put it down. I wanted to second Dr. Mitchell's excellent suggestions and just reiterate that these kinds of linkages are really powerful and where we can start answering those causal inferences questions. So
thank you. Yeah, and as we start to flesh these out,
get people into this situation, not just how to rescue them out of it.
right. I think linking the respective data sources is going to be extremely powerful, and there's opportunity to partner with other state departments and their state partners as we flesh these key outcomes out. And so we're definitely looking forward to that, not to work in a silo. Heather, did you? Liz, I see your hand up.
Thank you so much. This has been such an exciting meeting. It's thrilling to see all of this come together in such a short time, really. My comment is really building on Dr. Wilbur's comment. I think that we have always, when you're collecting data in a context that's changing, there's the challenge of understanding causality and understanding impact. And we have, in some ways, I think, having a really good timeline of events and actions that relate to the data over time is going to be important. So for example, we're doing quite a bit of investing in this current fiscal year in a number of programs. CalGROWS is an example, but the funding won't necessarily last many years, but the outcomes we're looking at are many years long. So having some ability to track policy, funding initiatives, when things come and go in terms of the investments, and then the foundations in our state are also stepping up and investing in really substantial, important ways. And so looking at those kinds of drivers of change and sustained change and impact, I think are going to be important as another level of understanding the data, because there'll be changes over time, but how we understand why those changes occur and what gets sustained will be really important elements to our interpretation of that data.
Great point, Heather. Yeah, it looks like, well, why is the change happening, right? What interventions causing that change? That could be challenging, but absolutely, it's important to track.
And which interventions are ones that we really should be highlighting for future investment, because they had, they made a bigger impact in a short term and looking for the longer term event effect.
So just on that note, this is not a complete answer to this suggestion, but I did want to put in another plug for the initiative tracker that has just been released, that West Health was instrumental in putting together, and Amanda Lawrence has been working on for a long time, because it does include in it some legislative aspects as well. So it's not just about implementation, it's also about funding and legislation associated with it, I believe, and Amanda and Zia can say more if they choose to, but I want to recommend the resource.
Thank you, Terry. I appreciate that.
Was there anyone else who had a question or comment before we move on here? And the next item, if you want to pull the slides back up, please, is about the research consortium, and Bella did a good job kind of explaining. Could you go back one slide, please? Thank you. The research consortium, and Bella, thank you for presenting the slide and kind of what we're thinking. It's extremely early on, obviously, we don't have any detail to share with you today, but it's a really exciting concept. And Bella, obviously, we're going to partner with her, but we'll have to open it up if other folks want to have input on this now, or if you want to get back to me, please let me know. But this is it's a very interesting concept that there's a lot of potential there. And if anyone wants to chime in with any thoughts right now about it, or if you want to kind of help flesh this out on a smaller work group, please let me know. So the next priority, I think, is the acquisition of key data sets. So as we start to flesh out these key outcomes and other efforts, I think discussions around data are going to arise in identifying these key data sets. So the acquisition of data will probably bubble up as a priority. Input on research needs and opportunities. This is related more to needs that may arise outside of our key outcomes and possible support that CDA may need on research activities. And that's why we put that there. So we can go to the next slide, please. So I think we've discussed this quite a bit already. So kind of the process for developing key outcomes, we're thinking that these subcommittees would develop 2 to 3 and then kind of work with CDA to flesh out our priorities and elevate up to 5 key outcomes. So unless anyone has any comments here, we can move on to the next slide. Thank you. So I want to discuss the upcoming research partnership meetings. So that they take place every 4 months. The next one's on May 19th, and then we have another one in September. So the May 19th meeting, we'd like to have the 3 work groups provide updates on progress related to the key outcomes and drivers. And hopefully the groups will have time to meet and discuss some progress here. We'll also provide an update on the research consortium development during this meeting. We're hoping the 4 months should be enough time to make some progress on these efforts. And then for the September meeting, we should have made significant progress on the key outcomes and can provide substantial updates at that time. So question for the group and for the respective leads. Thank you for that, Steve. So to CDA, we definitely want to help you help this group out. And you guys are extremely busy with these work groups. How can we help? Would it be helpful to help kind of schedule some of these meetings, and how else can we help you, the work groups, out?
So Ross, I think one thing I was just chatting with Leanne offline is that maybe we can create a document like a small survey or like a voting mechanism to share the outcomes and indicators with the larger group so they can provide that feedback to us. It's difficult to do that live, obviously. Yeah.
Absolutely.
So maybe we can work with you on sending out that questionnaire or survey and get everybody's feedback, and then that'll help us in identifying those, 5 or 6 that we move forward to you guys.
Thanks. Yeah, really good suggestion. Yeah, I think the smaller working groups are going to be a lot more productive in having this larger partnership meeting. And yeah, I think sending out a survey or something of that nature would be very helpful. Thanks for the suggestion. So I don't see any other hands or comments. So I think we can move on to public comment. And Nelson, I think I can hand it over to you to see if there's any public comment.
Ross, it's Megan here.
Oh, Megan, sorry about that.
It's okay. We have a comment, looks like a hand raised from Janet Van Zoren. So Janet, I'm going to unmute your line, and then you just click unmute as well yourself to be able to ask your question.
Thank you. Can you hear me now?
Yes.
Yes.
My question is well, it's not the typical question. But first I want to say I'm very pleased with what you're doing, and I think it makes a great deal of sense. And as not being a data person, I really appreciate the complexities of what it is that you're trying to do. My question has to do with the fact that so many decisions are data driven, and And because they're data driven, that also is how funding is appropriated and so forth for various services and whatnot. And on the one hand, that makes a great deal of sense to me. On the other hand, I'm concerned about the population of people who have diseases of early aging, because their data, when it's put on charts with the data of others, usually falls through the cracks when it comes to services for people who are aging with dementia. For example, a person with Down syndrome has a disease of early aging. They age at a much younger age than the general public. So when you look at the data for Alzheimer's disease for people with Down syndrome, and you look at the age, at the data for people beyond the age of 60, which is where you usually would look for that data for the general population, the number of people with Down syndrome on that chart would be very, very small, because most of those who got Alzheimer's have already passed by that age. And if you're looking at age 35 or 40, or in other words, at a much younger age, you'd see a much higher representation. And so what I find is that many times this population is falling through the cracks of the data that's collected and the charts and the graphs. And it's one reason that often they're not considered a population that should be in with those who require more equity. So anyway, I just raised this because I have no idea what the solution is, but I think it does complicate what it is that you're trying to do. And yet I fully understand from what all you've said, this is not something that you're trying to complicate in that manner. Thank you.
Thanks, Janet, for the comment. It's a very important point. Thank you.
Don't see any other hands raised at this time, Ross.
Okay, thank you, Megan. So I think we can go to the next slide here, and I think this is kind of wrapping up and looking forward to next.
Thank you.
Have a good weekend.
Thank you for a great meeting.